Alcohol, friend at parties, foe in the brain. Alcohol carries a unique role in discussions of memory and aging. It is often seen as a casual companion, social at gatherings, soothing in routines, yet it can act as an unrecognized driver of confusion and memory loss in later life. While many adults think only heavy drinkers face risk, the evidence shows otherwise, according to the National Institute on Alcohol Abuse and Alcoholism. Over half of people aged 65 and older reported drinking alcohol in the past year. For a younger body, a drink may burn off quickly, but for older adults, slower metabolism and body composition changes make even modest drinking more potent. What looks like just one may hit the brain as double or more, carrying consequences that build silently over time. The growing prevalence of alcohol use among older adults reflects more than habit. Retirement, shifting routines, and widespread cultural acceptance of alcohol as a relaxation tool all contribute to why so many continue to drink well into later life. Some describe it as a social bond, wine with friends, a toast at dinner, or part of group traditions. For others, it becomes a solitary nightly ritual, something that feels like a comfort or reward at the end of the day. Regardless of the reason, regular alcohol consumption in later life brings cognitive and neurological risks that families often misinterpret as age-related decline. Recognizing the effects matters, especially when early warning signs look nearly identical to progressive dementia. One of the best documented effects of long-term alcohol use is structural change in the brain. Older adults already face normal, age-related brain volume loss, but alcohol exposure can accelerate shrinkage in areas tied to memory and problem-solving. Families often observe slower recall, weaker attention, or blunted decision-making, and assume these are natural signs of Alzheimer's or vascular dementia. In reality, the changes often trace back to alcohol. Importantly, studies on alcohol-related brain disorders, sometimes referred to as ARBD, show that symptoms are not always permanent. Many people who stop drinking experience partial or even full recovery in cognitive function. That finding underscores an essential point. Alcohol-related memory issues may not be a fixed sentence, but a problem that improves when intake stops. Alcohol's impact goes beyond brain structure and extends to nutrition, particularly vitamin absorption. One critical nutrient affected is thiamine, vitamin B1, which supports normal nerve and brain cell function. Without enough thiamine, confusion, disorientation, and profound forgetfulness may occur. In extreme cases, chronic deficiency tied to alcohol use can result in serious syndromes that mimic severe dementia. The hopeful side is that with supplementation and reduced drinking, many symptoms improve. Yet, the obstacle is recognition. Families often assume these alarming changes represent irreversible decline rather than preventable nutritional disruption. Cerebrovascular health is another piece of the puzzle. Alcohol raises blood pressure, disrupts circulation, and increases stroke risk. Even minor strokes, sometimes called silent strokes, can accumulate and degrade cognitive performance. The effect may appear as subtle slurring of speech, clumsiness, or difficulty recalling words that once came easily. Over time, these small events compound into noticeable deficits. While dementia is often suspected, the underlying culprit may be circulatory injury worsened by alcohol use. With good medical care and a reduction in drinking, stroke risk can be lowered, protecting brain function in turn. Beyond long-range effects, the interaction between alcohol and medications deserves emphasis. Many seniors already take prescriptions for blood pressure, sleep, anxiety, or pain management. Alcohol magnifies side effects of these drugs, often unpredictably. An evening drink layered onto a sedative can trigger far heavier disorientation than expected. A dose of pain medication paired with alcohol may tip balance into dangerous territory, sometimes leading to falls or emergency visits. These incidents are not only frightening, they also deepen confusion in families who may interpret the episode as sudden dementia rather than a chemical overload in the body. One critical safety point is withdrawal. While some assume stopping alcohol use is simple, research warns that sudden withdrawal can be medically dangerous, even life-threatening. Risks include seizures and delirium tremens, conditions that require urgent care. For seniors accustomed to daily drinking, medical supervision is strongly recommended during detox, giving the brain and body a safer path to recovery. The encouraging perspective is that the brain carries resilience even in later life. Recovery from alcohol effects often begins quickly once drinking stops. Seniors who reduce or end alcohol use typically notice clearer mornings, steadier moods, and more reliable short-term recall within weeks. Longer-term abstinence correlates with stabilization of brain volume loss and measurable improvements in cognitive performance. It is not uncommon for older adults once believed to have progressive decline to regain independence after alcohol use is addressed. The message is straightforward. Symptoms linked to alcohol do not have to be permanent. Practical framing helps when addressing the issue within families. Comparing a nightly drink to a prescription emphasizes clarity. For an older body, the same dose has a stronger effect than it did decades earlier. What once felt harmless may now create memory gaps, confusion, or balance problems. Families who approach the discussion through health and safety, not moral judgment, see better results. Highlighting independence, clear thinking, or reduced hospital risks reframes quitting or cutting back as empowerment rather than loss. Many older adults respond positively when their choices are presented in this light. Conversations about cutting down face social barriers. Alcohol is rooted in traditions, holidays, dinners, and rituals of relaxation. Suggesting change can feel like intruding on something personal. But with knowledge of alcohol's outsized impact on aging brains, these discussions become acts of care. Offering alternatives, such as non-alcoholic beverages or lowering frequency, keeps social connection intact while protecting long-term health. What may feel like a small substitution can significantly reduce risks of falls, confusion, or worsening memory. Moving forward does not always require absolute abstinence. For some, occasional drinking at special events remains safe when balanced with awareness and healthy routines. The greater concern is daily use or consistent patterns, where the risks accumulate silently. Families who notice new lapses in recall or episodes of disorientation do well to ask one practical question. Could alcohol be playing a role here? This simple consideration can guide doctors in assessments, preventing premature assumptions about permanent decline. The crucial distinction lies in reversibility. Unlike Alzheimer's disease or other degenerative dementias, alcohol-related brain changes may resolve with intervention. Some symptoms fade within weeks, others over months, but the potential for improvement changes the landscape of what aging looks like. For seniors concerned about memory, alcohol is not just a social choice, but a medical factor tied directly to brain clarity. By confronting its role, individuals gain a stronger grasp on what is temporary versus what signals lasting disease. This pattern of misinterpretation, mistaking reversible, substance-driven memory issues for permanent dementia, recurs across cases. Families, uncertain of the cause, often panic when confusion or memory loss appears suddenly. Yet under closer evaluation, the timeline reveals key clues about whether the issue stems from substances or a progressive disorder. Understanding how to sort between those two possibilities becomes the next step, and it begins with asking where, when, and how memory problems first appeared, differentiating true dementia from substance-induced symptoms. When memory problems appear, one of the greatest challenges is deciding whether they stem from a medical illness like dementia or from the effects of substances such as medications or alcohol. At first glance, both can look very similar. Someone may repeat the same questions, forget where they were headed, or struggle to follow conversations. Families often assume dementia because it is the diagnosis most people fear with age. Yet doctors rely on a deeper analysis of timing and pattern before making that conclusion, and the difference can be life-changing. Research reviews suggest that drug-induced cognitive issues may actually account for an estimated 2 to 10% of dementia-like cases. That means a meaningful slice of people thought to be slipping into permanent decline are instead experiencing effects that could be modified or reversed. Understanding how to notice this distinction gives families both hope and a practical framework to use when they're uncertain. The timeline of symptoms is the key feature doctors use again and again. Decline from Alzheimer's disease or other dementias unfolds slowly, spreading over months and years. Early signs are often subtle, difficulty finding words, misplacing items, narrowing interests, and they advance in a steady, irreversible curve. Substance-related impairment, by contrast, is far less consistent. It can arrive suddenly after starting a new pill, adjusting a dosage, or drinking heavily for several days. Some people worsen sharply after an abrupt stop in alcohol use, as withdrawal causes delirium or disorientation. And unlike dementia, these symptoms may fade or improve when the substance use changes. For families trying to sort this out at home, it helps to follow a simple 3-part checklist. First, ask, did the problem begin suddenly or has it crept in gradually? Second, consider, did it appear after a change in medicines, drinking habits, or an attempted detox? Third, observe, do things improve when medications are stopped, adjusted, or when alcohol intake is reduced? These 3 questions, onset, relation, and improvement, form an easy guide that lays the groundwork for doctors to evaluate whether the cause looks more like true dementia or substance-related changes. Picture a case where someone begins a new pain medication, and within days, their family notices confusion around daily tasks. The rapid change and clear timing would raise suspicion of a drug effect. By contrast, someone who has been slowly losing language ability and independent judgment over several years, despite careful review of their medications, fits the pattern of a progressive disease. In one, recovery is possible. In the other, the trajectory is steady decline. That difference makes close attention to timing invaluable. Another way to visualize it is through how symptoms change over time. Imagine drawing a line on a chart. True dementia tends to slope steadily downward, rarely improving no matter what adjustments are made. Substance effects often zig and zag, clear some days, concerning on others, sometimes better once a medicine is removed. This uneven pattern is one of the strongest signals that the underlying problem may not be permanent. Families who keep even modest notes about when lapses happen and what substances were in use provide doctors with exactly the kind of information that distinguishes these patterns. It is not necessary to keep exhaustive journals. What clinicians value most are 3 concrete pieces of information: a current, accurate list of all medications and supplements, including over-the-counter items, the specific timing of when confusion or lapses began, and any recent changes in alcohol use or attempts to quit drinking. These details equip physicians and pharmacists to spot interactions, unintended side effects, or withdrawal effects that might otherwise be mistaken for degenerative disease. A neatly written list of pill names, doses, and behavior notes often illuminates patterns far faster than memory tests on their own. Consider Joan, who began forgetting where she parked only after starting a new blood pressure prescription. The clear timing pointed doctors toward the medication, and once it was adjusted, her memory gaps lessened significantly. Without that context, she may have carried a mistaken label of dementia for years. Frank, on the other hand, showed a slow erosion of language, problem-solving skills, and interest in activities over several years. The steady march across multiple brain functions, persisting even after medication changes, confirmed dementia rather than substances, as the underlying cause. These contrasts illustrate how the same outward signs can point in different directions depending on history and trajectory. Families sometimes struggle most with managing their own worry. Watching a parent forget a familiar name or misplace items repeatedly is alarming, and fear of dementia often rushes to the front. But stepping back to connect lapses to timing is more useful than reacting in panic. Did the repetition start just after a sedative was prescribed? Did confusion spike after a few nights of drinking? Or does it occur regardless of outside factors, creeping steadily through everyday life? Families who ask these questions arm themselves with insights rather than assumptions. Doctors, for their part, can only see a snapshot during visits. Memory screenings may highlight impairment, but those tests cannot sort whether impairment is caused by progressive disease or a temporary influence without the broader context. That is why families' observations and written records hold so much weight. Shared timelines bridge the gap between what is visible in a clinic and how symptoms unfold at home. One practical reminder is that reversible causes are not rare. The proportion of dementia-like conditions linked to drugs or alcohol is small but significant, and it represents real opportunities for better outcomes. When families hand over clear medication lists, symptom timing, and alcohol histories, they directly support doctors in recognizing these opportunities. The result may be a safer prescription plan, advice on reducing intake, or guidance towards supervised detox if needed. Each of these can restore clarity in ways that otherwise might have been missed. Ultimately, the distinction between dementia and substance effects rests on watching for suddenness, looking for links to external triggers, and noting any tendency toward improvement once those triggers are removed. Families that adopt this simple framework help both themselves and their doctors avoid mislabeling reversible states as permanent disease. Instead of despair, the process opens the door to recovery for some and accurate diagnosis for others. But even with clear patterns, the next hurdle often lies in how these concerns are discussed at home. Families may discover connections between nightcaps, sleep aids, or new prescriptions and memory lapses, yet struggle with how to raise the issue. And while gathering information is one step, delivering it without conflict is another challenge entirely, especially when it touches on habits and choices that hold deep meaning for a loved one. Family conversations without conflict. Family conversations about habits tied to memory lapses often feel like the hardest part of dealing with substance-related symptoms. This is where emotions run strong, where words can land wrong, and where relationships can either strengthen or strain. Families often mean well, yet the way something is phrased decides whether the discussion opens a door or builds a wall. With sensitive topics like alcohol or prescriptions, success comes less from forceful arguments and more from subtle adjustments in approach. One of the simplest shifts is reframing blame. When the concern sounds directed at the person, defensiveness rises quickly. But when the focus is redirected toward the medications, the mixtures, or the chemical effects, the discussion feels less personal and more collaborative. Instead of saying, "You're forgetting everything," a calmer option is, "It seems like the medicine is making your memory fuzzy." The difference is small but powerful. Research confirms that collaborative language, where the problem is defined as external to the person, encourages openness, while accusatory framing makes change less likely. Tone also matters as much as the message itself. A sharp critique like, "You're not making sense lately," feels final and judging. A gentler observation such as, "I've noticed you seem tired in the evenings. I wonder if the medicine plays a part," leaves space for dialogue. Seniors want to preserve their autonomy, and they are far more willing to listen when conversations are framed around supporting that independence. Saying, "We want to help you keep driving safely," signals respect for what matters most to them, rather than highlighting deficits. Active listening is another key element. Many conversations collapse because family members arrive with a speech rather than a question. Instead, inviting the senior to describe their own experience creates space to share frustrations or side effects that may have gone unnoticed. Asking, "How do you feel the morning after taking that pill?" Or "Do you notice if your evenings feel foggier on some days than others?" makes the discussion interactive. This shift from lecture to dialogue keeps dignity intact and increases the chances of mutual problem solving. Humor can be useful, too, provided it respects the person. Light comments that shift blame onto tricky pill bottles or complex schedules help soften the mood. A joke about how those little tablets are sneakier than they look diffuses tension because it makes the situation the culprit rather than the senior. Families should avoid humor at the elder's expense, but observations about the messiness of managing multiple medications can bring laughter while keeping dignity in place. This sense of being all in it together works better than confrontation. Because these discussions can feel overwhelming, having a clear, simple checklist helps families remember what to emphasize and what to avoid. 4 steps are particularly effective. Lead by expressing concern for independence. We want you to keep cooking those meals you enjoy. Point to the substance, not the person. The pills may be adding to the confusion. Ask gently about bringing a clinician or pharmacist into the conversation. Could we ask the doctor about this together? And offer to accompany them to the appointment. Would you like me to go with you? These phrases sound supportive rather than controlling, and families can rehearse them mentally before raising the topic. Research also highlights the importance of professional support in moving forward. Pharmacists, in particular, play a central role in reviewing medications. Evidence shows that pharmacist-led brown bag reviews often uncover duplications, interactions, or unnecessary prescriptions. Families who encourage seniors to schedule such a review by literally bringing every pill bottle to the doctor or pharmacist gain clarity and open the door to safer alternatives. Geriatricians also emphasize deprescribing, a thoughtful process of scaling down medications when possible. Encouraging loved ones to ask for a formal medication review provides credibility and reinforces that the conversation is about health and safety, not blame. Role-play style examples can help families practice. Instead of long stories, short sample lines are enough to demonstrate tone. A confrontational version might sound like, "Dad, your whiskey is ruining your memory." The cooperative version softens this. "Dad, I wonder if that nightcap and your medicine together are leaving you groggy. Should we ask the doctor?" In practice, the second version lands more gently because it points to the combination, not the individual. Short, practiced responses like these reduce the chance of arguments escalating in real time. Anticipating objections is crucial as well. Seniors often respond with, "I've been fine doing this for years." Meeting resistance with confrontation can escalate tensions, while acknowledging their perspective keeps the door open. Responding with, "That's true, you have managed it well. But since your prescriptions have changed, your body may be reacting differently," validates their history, yet still points toward the need for a new look. This balanced acknowledgement communicates respect for past successes, while framing the present issue as a new challenge. Another useful tactic is pacing. Expecting one conversation to resolve everything rarely works. Raising the issue gently, then letting time pass before bringing it up again, lowers defensiveness. Each time the concern is tied to a specific event, like a missed appointment or a confusing interaction, the connection feels more grounded. Over time, the repetition of these small reminders builds a pattern, helping the senior see the link themselves. Change is usually more sustainable when it is gradual and internally motivated rather than enforced from outside. Professional involvement also shields families from conflict fatigue. Sometimes, hearing the same advice directly from a doctor or pharmacist secures a breakthrough. Seniors may resist input from children, but respond differently when the recommendation comes from a trusted professional. Families can prepare by writing down concerns in advance for the appointment, ensuring the clinician has the full picture. This shifts the setting from a potentially charged home discussion to a neutral consultation room. Ultimately, the value of these conversations lies in maintaining trust. When families learn to reframe language, listen actively, and share responsibility with professionals, the dynamic changes from conflict to cooperation. Seniors sense that their dignity and independence remain central, while families feel relief in supporting without overstepping. The outcome is not just fewer arguments, but stronger relationships built on respect. In the real world, the tension often fades when both sides recognize they are not opponents, but allies against a shared challenge. The goal is not to catalog every forgotten item or habit, but to safeguard clarity, safety, and everyday freedoms. By treating medications and substances as the focus instead of placing blame, families create space for constructive solutions. Conversations that once ended in arguments instead become opportunities to adjust routines, explore safer options, and preserve quality of life. These approaches don't solve every problem, but they change the tone in meaningful ways. Instead of escalating disputes at the dinner table, families learn to talk in quieter, collaborative voices. Parents feel respected. Adult children feel heard. Both sides leave the conversation with the sense that independence and connection remain protected